Hello, everyone, and thank you for joining us today for our special panel session as part of our November prevention campaign for ISPCAN. The topic today is protecting children from maltreatment across all ages in challenging times. We have two wonderful presenters today, Dr. Sean Singleton and Barbara Gordon, and they have a special guest panelist, Janet Rosenweig. A couple tips for today. If you could please make sure that you remain muted during the presentations to avoid background noise. At the end of the presentations, we will go into a Q&A discussion. And at that point, we will invite you to turn off your microphones and to definitely join us in a very engaging conversation. We would also like to make sure we utilize the chat to its fullest. So please feel free to introduce yourself to other attendees in the chat. Also, if you have questions or comments during the presentation, please feel free to put them in the chat, but we will give you the opportunity to ask the questions directly and make your comments directly to our presenters. Also, as kind of a special feature today, please have your phones ready to scan a QR code that will allow you to participate in our audience polling. There are 4 questions over the course of the presentation. Each slide with a question will give you the barcode in case you need it and your phone kicks out. And then just a reminder that, as always with our presentations and webinars, a recording of this discussion, the presentations, all materials will be available on demand on the ISPCAN website, but also sent to you directly as part of your registration. Some goals for today's session. We really want to take a look at understanding the social determinants of health and the need for community collaboration in care. We'll be highlighting the importance of seeking accurate risk assessments through validated tools. And our end goal really is to give you examples of what resources can be built in any community to ensure the safety and well-being of families. Many of our examples are from the communities in which our presenters live and work. However, they're gold standard models of what can be really instituted in any community in any country. So at this point, we really encourage you to scan this barcode on your phone and join us in a slight polling. And our first question is, where are you joining us from today? So please let us know where you're from, what country, what region, or community that you'd like to share with us. Welcome to our friends from London, from the US, from Colorado, Arizona, Canada, Malaysia, Singapore, Utah, we have great representation from around the world. That's awesome. Welcome our friends from Japan, Milano, Italy. Awesome. Well, welcome to all. So setting the tone for today's presentations and really for our dialogue going forward is what we really want to know from you is where you live and work. What barriers have you faced when trying to implement prevention programs in your community? And I'm sure that most of you face multiple barriers, so please feel free to add additional Comments, you can add as many comments as you would like.
Yeah, funding, access to resources, lack of time. Absolutely.
Access to technology.
Community buy-in.
Not just
Intervention
funding,
needs-
but I was just going to say, I just saw not just funding, but sustained funding.
Yeah,
Mhm.
that's the hard part. Get some funding for a few months, a year,
Yep.
that goes away. Yeah.
Cultural
staff
evidence.
shortage. Again, I know that is a major issue
Yeah.
in the United States.
Yeah.
Taboo subject. That's interesting.
Yeah.
Entrenched beliefs.
Mhm.
And I'm sure there's cultural factors as well.
Yeah. Lack of mandate from probably government and regional resources. Yeah. 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 These are things that seem to be present here in the US and clearly across the world as well.
And I think potentially that gives us an incredible starting point, meaning that many of these issues exist in the communities of which our presenters live and work and have their programs established. So these were things factored in the creation and the implementation of their programs that they'll be presenting. Dealing with families in crisis, as opposed to probably getting out in front of the issues and from a prevention standpoint. Lack of mandate.
Feelings of suspicion, I would guess that's referring to the families feeling that they're being labeled or called abusive.
Lack of administrative will. I think that's a very powerful statement.
Yeah.
Lack of urgency.
Yeah.
Available evidence-informed programs. Hopefully we can help you with that today. Stigma, working in the community. Again, these are shared problems regardless of what community that you're joining us from today.
The access to technology too, and especially when you're in a rural area, for sure. Yeah.
Absolutely. Well, thank you all for participating in that poll. I think it's a great starting point to hand it over to our presenters. I want to introduce first Dr. Sean Singleton. Sean's a practicing pediatrician in Arizona. He attended medical school in Ireland and did his residency training at St. Joseph's Hospital and Medical Center in Phoenix, Arizona. Most of Dr. Singleton's career has been spent working as a primary care pediatrician. Sean's philosophy is that pediatrics is about a relationship with the child and the family, that prevention is a key to care, and in short, it takes a village to raise our children and support each other.
Mm-hmm.
And Barb Gordon. Barb transitioned into her role with the Birth to Five helpline in April of 2021, after serving as a training specialist in the Quality First redesign pilot for the 3 years prior. Barb has operated successful in-home and center-based childcare programs and is providing technical assistance, professional development, mentoring, coaching, and program management in early care and education programs. I thank you both for joining us, and we look forward to your presentations.
Thank you.
Good morning. Give me a second to share my screen. You guys can all see my screen, I hope.
Yes.
All right. So good morning and welcome, or good afternoon, depending on wherever you are in our world. I would like to thank you guys for joining us for today's talk and discussion on helping to identify risk factors for child maltreatment and the benefits of utilizing community, government, national, international resources to protect these children, to strengthen their families, and hopefully to reduce violence in their lives. Dr. Janet Rosenzweig is joining us today after I blind emailed her after a talk I heard. She will provide some very important information on preventing sexual abuse and sex education. She holds a BS in family studies and then received her MS in health education from the Pennsylvania State University. She earned her certification as a sex educator and in 1978 brought that perspective to one of the first child sex abuse programs in the country. She managed child welfare programs in Tennessee and Texas before earning her PhD in social work from Rutgers University. After a 25-year career in academia, public and nonprofit child welfare, she completed a fellowship at Harvard's Kennedy School of Government, earning an MPA. Then she served as the Vice President for Research and Programs at Prevent Child Abuse America. She served until being named the Executive Director at the American Professional Society on the Abuse of Children, APSAC, as a position she held for 5 years. Currently, she teaches at the University of Pennsylvania and lectures nationally. She is dedicated to promoting sexual health and safety. She wrote the book, The Sex Wise Parent, to further her mission of equipping parents to be the primary sexual educators of their children. So none of us have any disclosures to make. So again, we just want to review our risk factors for maltreatment by looking at the social determinants of health. We will quickly look at the negative social determinants of health and how they apply to risk factors for perpetrators of various maltreatments that are inflicted upon our children in our communities. I will go over the biopsychosocial model of health, looking at the need to employ validated screening tools to assess for stressors in our family and children's lives. Then we'll move forward to discuss the social ecology model of prevention of violence. We will talk about some local resources that we use and also the strengths of using the local resources when and where available. And then look at national and international resources that may be beneficial and helpful in your communities. So the social determinants of health really has been a public health focus. Look at the more effects of non-medical factors such as social policies on the health and well-being of societies and the individuals in our society. We do know that resources that enhance the quality of life positively do influence the population health outcomes in a positive way. Negative social determinants of health, such as lack of safe or affordable housing, access to education, public safety, good access to healthy foods, lack of local health services, living in environments that have health or life-threatening toxins do negatively affect our families' lives, and these are often associated with poverty. In 2020, a meta-analysis study demonstrated that these negative social determinants of health, including poverty, low parental education, lack of good housing, food insecurity, not having medical insurance, were found to be associated with child maltreatment and health risks. Both the CDC and the World Health Organization have recognized the risks to children across their pillars of the social determinants of health. They've incorporated these into specific tools to help combat the negative social determinants of health. These programs that they've developed these programs, guides, and policies can be utilized and implemented into our communities. The CDC has youth-specific programs looking at reducing youth violence everywhere. They have a framework to help states implement child-friendly and policies. They're also looking at moving from data to action on preventing of adverse childhood experiences and helping to find safe places for early care and education. The WHO's programs include, in their safety and mobility pillar, prevention strategies on drownings, falls, burns, and road traffic injuries. They also look at violence prevention, specifically looking at preventing interpersonal violence in all its forms, but really with a strong emphasis on protecting children from these. So some of the risk factors that we will look at quickly, are risk factors for perpetrating violence against others, especially children. I'm not going to read these lists to you. They're here for your review, but I would like to note the crossover and connection to the negative aspects of social determinants of health, especially as regards personal history of abuse and maltreatment, exposure to violence and in the home and the community, parenting difficulties or absence of parents, mental health and lack of mental health coverage, poverty, which may manifest itself as food insecurities, housing instability, safe house, and lack of safe spaces for children and families. The crossover highlights the importance of both detection of these risk factors and the need for effective intervention via utilization of our community government resources, because by alleviating these risk factors, we may reduce violence on many fronts. So just as you look through at these individual risk factors for abuse and neglect, we can see a lot of our negative social determinants of health with previous abuse, mental health issues, poverty, lack of access to parents. As we look at community and relationship, again, we see the negative social determinants of health. As we move into looking at risk factors for sexual abuse and violence, we again see those very similar or same negative social determinants of health propping up, excuse me. And as we look at relationship factors, community factors, and societal factors, again, those negative social determinants of health creep into our lists. This is borne out in the United States. This is our 2020 data looking at substantiated cases of child maltreatment across the entire United States. What we did find was basically in every case, one or more of these negative social determinants of health were present. So we do know from our data, and I'm sure data around the world would show the same thing, that these risk factors, while themselves do not indicate that a person will commit child maltreatment, when child maltreatment does happen, we often do find that these risk factors were present. So bullying is another area of maltreatment to our children. And again, as we look through these factors, we do see the presence of the negative social determinants of health. And as we look at the peer factors and school factors associated with bullying. As we move into risk factors for perpetrating intimate partner violence or domestic violence, again, in the individual factors, we see history of abuse and physical and emotional in children, low education, poverty. So we look at relationship factors, witnessing of violence between parents, unhealthy relationships, economic stress. So we look at the community, high rates of poverty, high rates of unemployment, limited education and economic opportunities. As we look at individuals who are vulnerable to human trafficking, again, we see the same things: involvement in the child welfare system, mental health issues. There may be political instability in these countries, addiction issues. Most of you may be familiar with ACEs from other seminars, but these are potentially traumatic events that occur in childhood. ACEs are common in the United States. Over 60% of adults who are surveyed reported they experienced at least one ACE, and about 16% reported that they have experienced 4 or more types of ACEs. When we look down this list, what we realize really is that this list that's on the screen of ACEs is a short list of negative social determinants of health that we see in the perpetrators of child maltreatment. So I see an overlap between ACEs and the negative social determinants of health. Toxic stress from ACEs can negatively affect a child's brain development, their immune system, their stress response, especially if they're always in a hyper state of arousal. Can also affect genetics, epigenetics. These changes affect the ability of a child to maintain attention, to make good decisions, and to learn. So the presence of negative social determinants of health are not just associated with the risks of being maltreated or engaging in maltreatment, but these affect the physical and psychosocial health of these children in both the short and the long term. In fact, that 16% who had 4 or more ACEs have somewhere between a shorter lifespan by about 10 to 20 years. So as we learn from the look at the negative social determinants of health and risk factors, we realize that we must regularly review a family's social history in whatever setting we may encounter them in. It may be medical settings, daycare, schools, religious centers, in extracurricular settings, or in community settings. If we don't look for these stressors, these risk factors, there's no way we can intervene to help these families, thus reducing the risk of violence in their communities and in their lives. The Everyone Project was created by the American Family Practitioners. It is available in 7 languages. It does look at the main areas of social determinants of health. They also work through how to intervene and help families who are experiencing these. The Hunger Vital Sign is a simple 2-question questionnaire, which can be self-administered or can be filled out by a provider. And it helps us determine whether or not the family is having any food insecurity, so we can help get them assistance. The Intimate Partner Violence screenings, there are many validated screening tools. The Minnesota Department of Public Health has created a comprehensive screening program. They have referral references for the intimate partner violence resources that they can administer during their home visits. All of these blue areas actually will link to the websites or forums I'm referring to. ACEs is from the acesaware.org website. And this website will help you learn more about ACEs. It will also help you learn how to use the tool, how to implement it in your practice, wherever you're practicing, and also has some general resources on how to help families and individuals who have experienced ACEs. As we saw in looking at our risk factors and the negative social determinants of health, mental health or lack of access to mental health is a huge issue for these individuals and these families. So the Edinburgh Postnatal Depression Scale is available and validated in 18 languages. It's available in other languages which have not been validated yet. It can be administered to both moms and dads. The American Academy of Pediatrics does recommend that we administer this throughout the first year of life. The PHQ-9 is a depression screening test. It has been modified for use in adolescents. Where I used to work, we administered it to every teen at every visit. The AAP and the Bright Futures have a publicly available PDF that you can look down and find all links to all of these screening tools that are here, plus additional screening tools looking at developmental, looking at other screens for adolescents, and in younger children, adolescents, the behavioral, social, and emotional scales, and the ADHD. So next, I want to kind of move from our theory towards our practice. The biopsychosocial model was first conceptualized back in 1977 by George Engel. He emphasized that a person's medical condition is not simply due to their biological factors, but also that psychology and social factors play a role. If we utilize this will give us a fuller understanding of the person and the effects that are affecting their current health. In the US, we are taught this model both in medical school and residency, but applying it, in my opinion, has been problematic and traumatic, especially if we don't apply it in a trauma-informed way. I feel it's not well implemented for a variety of reasons here in the US, such as a production-based model, where the more patients I see and the more money I generate, the more money I will make. Our society is very litigious. Many of our medical offices are not accessed with a social worker, or they're not aware of all the community resources. We also use electronic medical records for the most part, where we have checklists where we can say we completed this requirement or that requirement, so our data is full. The health, we're going to now talk about actual prevention of maltreatment and some parenting tips. The health system I work for provides services in 6 Western states. This is a very large area. There are a lot of community resources that are specific to the needs in each community. Our team has compiled a resource list with local resources, reputable national and international groups to help guide our providers and help families in their community. Local resources are an important way to meet the needs such as food, clothing, and shelter in many of our communities. Educational needs are often best resourced from national groups such as the American Academy of Pediatrics, their healthychildren.org website, the CDC, or from international groups such as the WHO and various countries' health and professional organizations. However, there are often local groups which can meet the education needs for specific populations. One such group is Southwest Human Development and will be discussed by Barb Gordon shortly. We will provide the links to these national and international resources broken down by maltreatment type for your review and utilization. They'll be included at the end of the talk. Some will also be posted in the chat. If you're local to Arizona, I'd be happy to email you our resource list, or if you have resources we don't have, I'd be happy to look at them and add to our list. As we discussed, there are a lot of overlapping and connecting features seen in risk factors associated with family and child violence. To understand the benefits of developing patient resources, community resources, we need to look at the social ecology model of prevention. This model looks at 4 levels: the individual, the relationship, community, and societal factors. Effective prevention measures need to span these 4 levels, ideally at the same time, because effects from one level may be additive to another. This does not mean that we all need to engage and work on the levels that we're not comfortable or where we don't have expertise. During the rest of this talk, we'll look at individual and relationship levels. The individual level looks at factors in people's lives, and the relationship levels of our close relationships, such as our family and peer relationships.
Good morning, everybody. Again, I'm Barb Gordon, and I am proud to say that I work with the Birth to 5 helpline, and I'm so excited to share this wonderful program here in Arizona that we see as one of the major protective factors for families that have all of these issues going on with them. So next slide, Sean. I'm going to start by sharing with you about Southwest Human Development as an organization. We are the largest nonprofit agency in the state of Arizona, and we are dedicated to early childhood development. We've been around for about 38 years now, and our mission really is to strengthen the foundation that children need for them to have that great start in life. The majority of the programs at Southwest Human Development focus on birth to 5 years, but we do have some programs that work with families with older children as well. But really the focus on birth to 5 because and I know a lot of you know this, everything starts in birth to 5, right? That's what takes place in those first, well, the first 3 years for sure in terms of brain development, and the first 5 years with their continued brain development. And so we just know that as an agency, this is where the focus needs to start. We currently have about 900 staff members, and we have about 40 programs, and we are currently serving somewhere around 140,000 children and families, primarily in the state of Arizona. And I say primarily because as you'll learn more about the Birth to 5 helpline, sometimes we do get calls from families out of Arizona, so it's really kind of interesting. We have some key focus areas for our agency. One is child development and mental health, and that's where the Birth to 5 helpline resides. We also have Easter Seals Disability Services. We really heavily focus on early communication, language, and literacy. We have funding for both Head Start and Early Head Start. Currently, we're in about 5 of Phoenix's school districts. We also focus on family support and child welfare. So we have programs that focus in on foster care, helping to license foster care, families, kinship care, and we provide supports for those individuals as well. We have home visiting programs. We have nurse home visiting programs. So if a family has a high-risk pregnancy, has a child that is a preemie, we have all kinds of services for those families as well. And then we also have a whole department that's focused in on professional development and training. And primarily the focus of that program is for child care providers. So we target early childhood child care providers, both center-based and home-based providers, and provide them with training and resources to be able to do the best job that they can while they're caring for these kids that are, from birth to 5 years old. Next slide. So I want to share a little bit now about the Birth to 5 helpline, which really is such a unique service. It's a statewide service. There is no cost to access the helpline. And let me also share that there's a difference between a hotline and a helpline. A hotline tends to be an area where you can call and they're open 24/7. With the helpline, we are on the phones Monday through Friday from 8 a.m. to 8 p.m. So although we do get crisis calls like you would see at a hotline, the helpline, it works in a very different way. And I'm obviously going to share more about that. We're here for parents, we're here for caregivers, we're here for early childhood medical providers. We get social workers calling us with concerns or questions about a family or children that they're working with. Our helpline team is highly trained early childhood specialists. We all come from a variety of backgrounds. We all have years of experience working in areas of early intervention, early childhood mental health, social work, and then early childhood education. We do have 3 people on our team. We're a small but mighty team. There's only 6 of us on our team, but 3 of us do speak Spanish. And if a family was to call in with a different language, then we have access to an interpretation service that we can get an interpreter for whatever the language is, including we are able to work with families that use ASL that are deaf. So we can meet the needs of everybody that calls in. And as I said, we're a unique program because every single call that comes in is handled on an individual basis. What we do is we want to listen to the caller. We want to know where the caller is coming from, where they're at. We ask clarifying questions. We follow up on the questions and the answers because it's really about getting to know who the person on the other end is and what their needs are. One of the best things about the helpline, and the reason why I love working on it, is that we're not timed on our calls. So our call can be 5-10 minutes. Our call can be an hour and a half to 2 hours with a family. We're going to take as much time as that caller needs so that we can really get to know what's going on, what's going to be most helpful. And sometimes our calls are not just one and done. A lot of times I have so many families that I hear from on a regular basis. I may not hear from them for a couple, 3 months, and then boom, something's happening. So they're calling to say, hey, you helped me last time, and now this is what's going on. Can you help me now? We all are very highly trained in terms of having the capacity to manage our own emotions, to bring our knowledge and experience into the conversation, but not from an expert way. We are not telling the family. We want to know what the family is doing, and then we will offer strategies, but it's through a conversation that we're doing together. So we don't always rush for a resource. We really, again, want to understand and meet the family, the caller, whether it's a social worker or a parent, where they're at. And it's really kind of a remarkable thing if you think about this, because where can you go and talk to a professional who has all the time in the world for you, who isn't going to be rushed, who doesn't have another call or another client or another patient waiting, behind another door? We're here for you. Um, and in terms of the resources that we give, which I'm going to share a little bit more about that in just a minute, but we don't do cookie cutter approach of resources. We want to know, we want to give the families the resources that are going to best meet their needs. So we ask questions like, what insurance coverage do they have? Where do they live? Have they tried reaching out to different organizations, and what's been their experience? So that we really can tailor what we're giving them to meet the needs that they have. Do they have transportation? It's so easy to just assume that people have transportation or access to a bus, and Arizona can be very rural in a lot of areas of our states, and so sometimes transportation is a huge barrier. Um, so who calls the Birth to Five helpline? It's really everybody and anybody. And I always will tell callers when they call and they're a little bit hesitant, I have a 12-year-old and I don't know who to call. You called the right place, because we're never going to hang up from somebody that is calling us. We're going to figure it out together, and go from there. So really what we're doing is we're working together to kind of help resolve whatever the issues are. You can go to the next slide, Sean. So why do people call the helpline? These are some of the most common topics that people call about. It could be that they have a newborn or they have a 2-year-old that's having sleep issues. It could be that they just have general questions. Maybe their baby is not rolling over or sitting up, and so they're kind of questioning about that. Um, they might have challenging behaviors, especially around preschoolers. This is a common area that we get calls from childcare providers about. They have a kiddo in their classroom that they're having a hard time with the behaviors, things like that. So sometimes we'll get a call from a parent who's just looking for marital counseling, doesn't have anything to do with their child. They just want some parenting classes, or they want marital therapy or something like that. So it's just a huge variety of reasons why people call us. We have a special project and that we are working on, which is really focused on perinatal resources, so that we can touch those families, those moms who are in pregnancy, and we know that they may have lots of risk factors, some like Sean was sharing with the ACEs. And so we can really focus in and work with those parents as well. And it's one of the first ever statewide efforts to support moms and families in that area. Next slide, please. Our agency has worked really, really hard to make sure that this system, the Birth to Five helpline, is super simple to access. We have texting capability. You can email the helpline. We wanted to make sure that we were reaching everybody, including our millennial parents. And so we also have an app that you can download onto your phone, either through Google Play or through Apple. And that gives you complete access to the Birth to Five helpline. We're really aware, we all just came out of the COVID pandemic, and we're not even out of it yet, but we know that the consequences that happened with a lot of families and a lot of young children with the isolation really caused a big increase that we're seeing, at least at our end, in terms of anxiety and depressive disorders, not just affecting the adults, but affecting these young children as young as 1 and 2 years old. And so we want our service to be available to everybody. We want it to be super easy to access. We want people to be able to connect with us, so that we can be there to support in whatever way we need to. The next slide. Whoops, we're getting there. There are a lot of different models and ways. Go to the next one, Sean, please. There's a lot. What happened? It's the one that has the fan on it.
That was the last slide that I had for you, unless I forgot to copy and paste one in. I thought I had hit them all.
There's actually a couple more. So I'll just kind of verbally tell you. So there's a lot of different models out there in terms of working with families. And at the Birth to 5 helpline, we utilize something called the FAN, and that's the Facilitating Attuned Interactions. It's actually a model that comes out of Erickson Institute in Chicago, and it's really about taking the time to be with the family, and it starts with us as the specialists. It really looks at us calming ourselves, being mindful, making sure that we're present for the caller. And then through the conversation, we start with some empathetic inquiry. We kind of get to know the family a little bit. Then we move into some collaborative exploration, like what have they tried? What have they not tried? How is that for them? How are they feeling about it? And then we move into capacity building, and that may not happen in the very first call. That may happen in a follow-up call, but we really want to work with them to figure out what's going to be the best resource, what's going to be the best strategies for them to try, and really help them. The other thing that we will do too is just by listening and really truly being present and listening. A lot of times you will hear a family or a parent say something, share something that they've tried and it's been successful, but they don't stop to think about it as being successful. And so we have the ability to hear that and bring awareness to them that, wow, you tried that and it worked, and that's amazing that you were able to do that. Because sometimes that can be missed, those little things, and it's just a way to help build up their capacity. And then we always end our calls with reflecting. We want to know how the call went for them, what are their questions, and we always try to do a follow-up with them. Can I check in with you in a week? Can I check in with you, in a couple of weeks, so that we're making sure that they've gotten what they need from the call. So the FAN, the Fussy Baby Network, Facilitating Attuned Interactions, and I can put a link in the chat after I'm done so that you can look that up. It's really about listening to the family. It's understanding where they're coming from, and it's just meeting them where they are. So it's really about attunement. So that's some information about the Birth to 5 helpline. Like I said, I'll put some links in the chat right now so that you can go onto our website. You can specifically look at the Birth to 5 helpline website. You'll also see our Fussy Baby program, which is a unique home visiting program that we do for families that have children under the age of 1, where we can focus in on a specific topic. Might be sleeping, might be feeding, could be anything. So yeah, so thank you, and I will put the links in the chat.
Sorry about that, Barbara. We will make sure those additional slides are included in the PDF that we send out to you guys. I have sent and given the phone number for the Birth to 5 helpline to nearly every family that I've worked with, recognizing that they have more expertise in a lot of those areas than I do. And every family that utilized the service had nothing but good things to say. It is a great model, and it is a great protective effort for children. But as we know, parenting questions, struggles, and stressors don't end once the kids enter school, and they don't end for the kids. So in Arizona, the discussions of discipline in older kids are often and mostly driven by medical and school professionals. We really need to make sure, again, we're recognizing these kids, these parents in stress. We may need to offer support to the parent, whether talking about self-regulation. And as Barbara pointed out, we need to have self-regulation. We may also refer to parent groups if in the area. I'm always dubious and worried about online programs, but if you're going to recommend something, make sure you research it and look at it to make sure it's something that is reputable and is helpful. Parents and teens really trust what we have to say, but they need to feel heard and to be a part of this conversation. So as Barbara pointed out, it's important to have a conversation. It's important to make sure we're listening. We don't want to have a lecture. We don't want a canned speech. So, for instance, we want to discuss their views on corporal punishment. I want to understand why the family feels that they think corporal punishment is needed, what they think they'll get out of it by using corporal punishment. Then that's going to allow me to start talking about what kids actually learn from corporal punishment, which we know is often that you use violence or aggression when you're angry. Also, that kids often go back to the behavior that they were doing that got them in trouble within minutes. I also like to discuss the damage that corporal punishment causes, not just both physically, but psycho-emotionally. And then I do want to really talk about offering effective parenting skills. And this is to the middle point, is discussing about the child's development, their stages of thinking, which is going to help set realistic and age-appropriate expectations of the child. A lot of parents don't necessarily know what it is that a child should be able to do and how a child should think at certain ages. So they have these unrealistic expectations, which leads to potential of increased frustration and may increase the risk of violence. So I like to discuss different discipline techniques and explain that discipline is about teaching. It's not about hitting. So I will discuss timeouts, proper ways to use them and not to overuse, using a positive and negative reinforcements, and the importance of catching children being good and being specific with what the child did. Thanks, honey, for helping me put the dish away. I really like it when you help me. That is going to help mold and shape their behavior. So these are specific ways we can help the family. Some of my most favorite handouts that I use are from healthychildren.org. It provides information for parents and children from when mom is pregnant to when the child becomes an adult. But when you're giving these handouts, similar to what Barbara said, don't just give the handout. Be familiar with what's in it. Perhaps review parts of the handout, highlight it, circle with the parent or teen. You'll get much more buy-in of actually going home and looking at it. Instead of just saying, here's a pile of papers, read this. I've actually had kids come back and say, well, I had to tell my mom to look at that again because you had gone over this with us. If we review it with them, they will look at things. So bullying is very common. It's more common than child abuse. So this is a very important area of maltreatment that professionals need to be familiar with. In the US, it's estimated that every 7 seconds during waking hours, a child is bullied. This can be physical, it can be verbal, it can be social, it can be cyber. School data has shown that bullying is much less common in our elementary schools. It's highest in middle schools for both in-person and cyberbullying. The bullying continues into high school, where the cyberbullying rates are pretty similar to what we see in middle school. In addition to happening at school, bullying can happen at home, can happen in other centers where kids are on. So providing education in those areas is something that's very important. Bullying is also much higher in certain groups, such as youth in the LGBTQIA groups, in young women, and other people with disabilities. And it does have lifelong lasting effects if we don't intercede in both the bullying behaviors, but also making sure that the children who are being bullied and the children who are bullying get some help. So through the CDC, and who, they have some great resources. The resource I like to go to is stopbullying.gov. They do provide some resources on how we should approach this. And some of the things we can look at is we want to talk to the kids about bullying. We want to talk about it often, see what's going on, hopefully before either they experience bullying or they do some bullying. Use our relationships and our experiences from our childhood to relate to what's going on in the kid's life. Being a kid is tough, and having cyber or having social networks and internet may make things more difficult. And talk about it kind of in a general way so the kids will understand that bullying doesn't happen in just one way. So other good resources for this are some of the handouts from healthychildren.org, which I've linked to at the end of the talk for you. In the US, every state has anti-bullying laws, and most states have anti-bullying policies. So if a family comes to you about a kid being bullied in school, you may need to send a letter and support. You may be willing to make a phone call to the school. Children who are being bullied or who are doing the bullying, we really want to make sure we focus on their behavior, because behaviors can be changed. We want to understand what's going on around that event and perhaps other events. We want to ask how they were feeling, if they understood how the other child was feeling. And then we may start talking about, are there other ways we could have handled the situation better? So again, we're trying to give examples and use resources that the parents can relate back to, instead of reacting just to the child instead of their behavior. Intimate partner violence is very common as well. We often think about it as physical and sexual violence, but it does also involve psychological aggression and stalking. In the US, 41% of women and 26% of men report that they've been victims of IPV at some point in their life. It starts young. It starts as dating violence. A US study looked at high school seniors. 1 in 12 reported they've had physical abuse during dating, and 1 in 12, not necessarily the same 1 in 12, reported that they had sexual dating violence. Intimate partner violence is preventable. So some of the things we need to do, as you can see in this table here, is really work on teaching safe and healthy relationship skills. So we want to talk about that with our families. We want to utilize handouts. We want to also talk about signs and symptoms of unhealthy relationships, so a child can recognize when they're the victim or when they may be starting to engage in unhealthy behavior towards their partner. We can involve, if it's available, community programs through things such in the US, such as Boys and Girls Clubs, other things where we can have influential peers where they can discuss these issues, have mentors, such as these Men to Boys. These are some programs here in the US that have been found to work with kids who are exhibiting violent behavior, so they can see how, what I would say, real men act and don't act in a violent way when we're upset, but utilize other resources. We can look in our communities where they can create safe environments, and we can also support families who may be going through some of these economic issues. If we do identify a family experiencing intimate partner violence, it's important to have your resources available, what's in your community. So you want to know, perhaps in a handout, what shelters are available. What kind of resources does the shelter have? Are they private rooms? Are they dorm rooms? Do they accept pets? Some families leave in a hurry, so you want to know, does that shelter have clothing? Do they have access to food within the shelter? What about counseling for the partner who's being abused, for the children who may have seen this? Are there legal helps if they need it? Phones are an important thing to consider too, because phones can be tracked. They can be emails and all that can be hijacked. In the United States, Verizon Wireless actually has a program where they will provide free phones and free internet and wireless service to victims of intimate partner violence. We do have a link for that for those of you that are in the US. In our state, we do have, through our Department of Economic Security and a governor's panel, is a coalition to help to end sexual and domestic violence. They look at providing these resources and providing training to community groups. So sometimes some of this will start from the ground up, and sometimes will come from the government, highest government levels down. I want to move on to human trafficking and exploitation. This is another thing that does happen to our kids. It happens all around the world amongst all groups, all socioeconomic levels. Youth victims may enter trafficking but still live at home. So it's important that we work to train our staff to make sure we know how to recognize features of trafficked individuals, because most of these individuals in the US at least report that in the months prior to being identified as being trafficked had actually been involved with our health system and no one was aware or thought of trafficking. So the International Center for Missing and Exploited Children has some great training. I've attended a few of those. Here in Arizona, we do have, through the Arizona State University social work program, a team that will provide training for providers and health systems. And again, the governor's office has a campaign to help end human trafficking through awareness and funding. So it's important that as we get trained, we also conduct safe interactions. We interact in a trauma-informed way because we don't want to necessarily re-traumatize these individuals. Since we're mostly talking about children, here in the US, if we are concerned that a child is being trafficked, we do need to report to Child Protective Services, to law enforcement, and we should discuss this with the child and or the youth and explain why. It is recommended that we also report this information to the National Trafficking Hotline. Some of the resources that we've used and utilized and created documents, which will also be shared with you, are access to the National Trafficking Hotline here in the US. In the US, Polaris has a text that anybody who's being trafficked, youth or otherwise, can text and mention where they are and someone will come to help. Safe Spaces is another nonprofit here in the US that provides similar services. And what I learned a few years ago here in Arizona is that the QT gas stations, and they're found in other places in the US, actually fund and are a safe place for at-risk youth. So you can look for these groups in your community, which maybe would help, or you can look at them as a model for perhaps which we need in your community. So hunger and economic stressors, these are things that are very common, definitely in our community, and probably very common in a lot of other communities around the world. So what I have found is that most of the programs to help relieve food or economic stressors are run locally by nonprofits, or they're run through the state in the US from federally mandated programs. I found during my practice, it's important to have the numbers for these programs. So for the food pantries, which are often smaller locations of larger food banks, because not everybody has access to transportation, as Barbara pointed out, and have the numbers available. If we're talking about some of the governmental forms, WIC, which is Women, Infants, and Children, where they provide nutrition for kids and families under 5, including formula, or our supplemental nutrition assistance program, having those forms available in the office to help fill out, because there may be some literacy issues, is helpful. If it's possible, and I also like to know about the school meal programs. So in the US, a lot of times, some of our school districts will have school meals. I want to know where those school meals are being offered. Are they being offered only during the school year and during the school week, when they're available? Because sometimes for some kids, those are the only avenues of getting regular, solid, and healthy nutrition. If it's possible in your practice to have someone in your office help fill out the forms or go online and fill out, because again, they may not have access to phones that work all the time. They may not have access to internet. So by filling out the forms in the office or online, we can help get that, make sure that they're enrolled and get them going. When we look at economic stressors, a lot of times we see families who have troubles paying utilities, paying rent, issues with their pets, and a lot of other things. In Arizona, we have a program, az211.org. It can also be accessed by calling 211, which does not require active phone service. This will help them get set up with the specific and correct program to assess their need. It also will help them sign up for various government programs. This group of youth, they're LGBTQA, I wanted to present it as its own slide because they're at such high risk for maltreatment, both at home and the community. And their risks include physical abuse, bullying, sextortion, intimate partner violence, trafficking, homeless, mental health disorders, including increased risk of suicide and substance use. And because these risks to these youths are extreme in our opinion. We created a specific list to help them and their parents in our service areas. So we've divided up as Arizona and what we call the Western region. So these are US resources, but from what I understand, the groups listed below, the PFLAG, GLAD, GLESSON, and Trevor Project will help youth from anywhere find resources in their country. This is regardless of your personal opinion about LGBT, we need to make sure that we help that youth that is there and make sure that we do everything we can to keep them safe. So now Dr. Rosenzweig will take over and talk about human sexuality and protection of child abuse.
Greetings, everyone. And I want to thank Dr. Singleton for inviting me to join this presentation. For those of you that joined us late, I'm sort of the special guest person with a very brief presentation about a very specific area. When we talk about prevention, the area that I like to focus on is preventing of child sex abuse. I've been working on this since like the late 70s, but I come from a very specific perspective because I came into the work in child sex abuse with credentials as a sex educator. I have learned in my 40 years of practice, and research has backed up, that accurate information about human sexuality is a very critical protective factor in child sex abuse prevention, but it's not widely available. I'm going to both start and end with the same call to action. In so many communities, we're talking about sexuality as a taboo and really not allowed, and in some places could even be punishable. Those of us that work in child health, those of us that work in child welfare, those of us that work in keeping children safe, we're one of the few people in some communities that have permission even to talk about sexuality to kids and families anymore. And I urge you, this will be a brief introduction, that if this area interests you, that you learn more about it and we can stay in touch and see how to do that. Why is accurate information important? Number one, children need accurate language to communicate about sexuality. If they don't know how to put words to what someone is doing to them, they don't know how to seek help. Kids need healthy sexuality. You know, parents need to be supported around this issue because the most important lessons, the most primal lessons about human sexuality happen at home. We learn from early touch about love, trust, physical pleasure, all the stuff those of us, you know, when we talk about early care and education in the perinatal field and the infant-child bond, that's setting the stage for people to be able to interact with people in a loving, healthy, non-exploitive way. And perhaps the most important reason, and again, this is something that I'm going to repeat at least twice in our few minutes together, children and grown-ups need to understand that genital arousal is an autonomic reflex, okay? The kind of information individuals and families need is not widely available. Looking at some things that happened in the US, when I can tell you it was much more widely available in the 60s, 70s, 80s, and 90s. And by the time the 90s happened, I'm sorry. I'm just going to assume that was an act. Okay. We saw in the 90s when we started first in the United States, started having sex offender registries open to the public. So parents started to think that all they had to do was check a registry, and if there were no offenders in their neighborhood, that they were okay. We saw a huge influx of federal money for abstinence-only sex education, which meant that people who wanted to talk to kids about sex were only allowed to talk about certain topics that really didn't let them cover all the ground. This also not just funded schools, but it was also some youth serving agencies. And we saw in our country a eminently well-qualified Surgeon General, Dr. Jocelyn Elders, was forced to step down from her position as the Surgeon General of the United States for answering a question about masturbation at a World AIDS Day conference. So if the Surgeon General can't talk about masturbation at a World AIDS Day conference, None of us are going to talk to folks. Can I hit my next slide, please? So one of the results of what I've come to refer to as the neutered 90s is that adults, even the well-intentioned ones, stop talking to kids about sex. And now 20 and 30 years later, this generation who grew up without access to good information, they're now trying to raise children. They're now us, or younger than me, but you guys that are out in the field, that we really need to help empower them with the good information. We need to be able to connect with professionals and community-based organizations that promote sexual health and safety. My point of view is I like to work toward empowering parents to be able to present this information within the context of their family, their faith-based, and their values. Do I also believe it ought to come from schools and youth agencies? Sure, but that in many communities becomes politicized. No one fights when we think of the social ecology and we think about going from individuals to families up the line to community norms. No one will object to a parent's right to talk about these issues to their kids. So my personal focus is how do we support parents to do that? Can we have the next slide, please? Probably, again, the most important thing that we can make sure that we have, medical fact that we can make sure people understand is that genital arousal or human sexual arousal, it is an autonomic function. It comes from the part of the body, of the brain, that controls things that are not consciously directed, such as breathing, such as heartbeat. People don't just decide, oh, I'm going to get aroused. It happens when a stimuli, a memory, a thought, a vision, a smell, a touch makes the body begin this autonomic process. Next slide, please. So what happens, again, recognizing that arousal is not consciously directed is absolutely key. And there's a couple of reasons for that. Next slide, please. Probably the most important is that when kids are victimized, and I see someone put this in the chat box, victims may experience a genital response while being victimized, and predators often use this response against them, convincing the child that they were a willing participant because they quote unquote enjoyed the act. Those of you that remember your early psychology classes may remember the word schizophrenic, which is when we try to tell someone to experience two realities at the same time. So you have a kid being victimized, experience something that they know in their intellectually is wrong, but their body is telling, my God, I've never felt such a strong, powerful, pleasurable feeling before. This is one of the key reasons why understanding that response is autonomic is such a powerful protective factor, because it takes away this very nasty tool that predators can use to engage kids. And it's in many cultures who don't understand this, the grown-ups, the law enforcement, the social workers, the parents, the clergy, they'll blame the kid because the arousal occurred. And that's just a physical fact that certain types of touch and feelings will stimulate the response. Is again, wildly confusion, especially for kids who were raised and all they ever heard about sex abuse prevention was the concept of good touch, bad touch. Maybe we go with inappropriate touch, maybe we go, boundary violating touch. We must stop teaching sex abuse prevention in terms of good touch, bad touch, because when a child, that's all they've heard, and yet what someone did to them doesn't actually hurt and in fact may feel physically good. It is terribly, terribly confusing, and we make them feel as if they were complicit. I've had adults that were victimized as kids hear me say this in workshops and just be incredibly thankful that someone is finally explaining to this. And last but not least, the other reason that it's critical is adolescents. They have developmentally age-appropriate, very poor impulse control. When they experience genital arousal, they may think it's a call to action. In the United States, when we look at our statistics on sex abuse and we're realizing how much of it is now happening, peer on peer, the 15-year-old to the 5-year-old, the teenager to the toddler. If no one has taught this teenager that their arousal is a developmentally appropriate things that happen because their body is growing up, and that arousal is nobody's business but their own, they might find it a little bit too easy with the adolescent lack of impulse control to share that arousal inappropriately with another kid, one with whom they've got power over, and that is sexual victimization. Next slide, please. There is very good research that talks about ways that we can promote comprehensive sexuality education as a means of preventing sexual violence. When you get the slides, you'll have a link where you can grab these studies yourself and see, and see what pieces of this can be useful to you. Next slide, please. One of the things we hear from parents is that if I talk to my kids about sex, they'll think I'm giving them permission to do it. We've got very good research that shows us a couple of things, that parents communicate important information to their kids. I recommend this review to you. And the next slide, please. We know from this another study that when parents are the sources of information, sexual health and safety actually increases when they have access to good information. Next slide, please. Another key reason to understand the whole arousal piece is that sexual arousal influences decision-making and restraint, so when we start with this victim blaming, for example, we just need to understand the autonomic response that comes with genital stimulation, and there's so many different things it can be doing, both for a perpetrator and for a victim. Next slide, please. So if more information on the topic, there's my name, my email, a couple of the slides of some of the books that I've written, but I absolutely will be here for the discussion and the final part of this presentation. Thanks, Dr. Singleton, for bringing me in, and back to you.
So thank you, Dr. Rosenzweig. What I found in my primary care years was I never had a family from any cultural background object to me talking about puberty, talking to them about sex. I never did it as eloquently as you, but it also helped the families begin that conversation. I would often suggest that they not talk specifically about sexual act, but talk about puberty, talk about relationships, talk about the body, and then move on from there, giving the child permission. So again, not nearly as eloquent as you did, but it is an important topic. And I think most parents are grateful to hear us as professionals, perceived as experts, and perhaps are experts, start that conversation. So what we want you guys to take home from this is that maltreatment of our youth is prevalent. It happens in many fronts. It is associated with the negative social determinants of health. There are efforts being made to combat those. We really want to make sure we identify and are aware of risk factors for maltreatment. And it's important for prevention campaigns. We can try to utilize this social ecology model to address prevention at all levels, engaging with what our government is doing, perhaps getting on task force, perhaps seeing what's available in our communities. We may not be experts. I am not in developing a program, but in helping to assess it and determine if this is something I want for my families, I can do. We want to make sure that we're able to intervene and help reduce the stressors. And this is going to where we're refer to our local community groups, utilize national, international resources, including people like Dr. Rosenzweig, to communicate with us, to teach us and to train us. And then connection, collaboration with these community groups helps improve utilization by the families, but also helps families connect with other resources. As Barbara pointed out, they're not going to say, oh, you're too old for this. They're going to, our helpline, but we're going to help you find resources. So these are ways we can hopefully help build and strengthen the safety nets in our communities to help protect the families and the children from experiencing violence and perhaps from going on to perpetuate violence in their lives. These are just some of the resources that I used and links. They should all work. If they don't, I will provide my email address in the chat because I realized I did put it here on the slides. You can email me any questions or more resources that I need to know about. let me stop sharing and Jan will take over.
Thank you, Sean.
Yeah, why is it not letting me? Why is it not letting me stop sharing? Oops, I clicked the right button.
All right, everyone, let me get my slides to the right spot. I do want to encourage everyone. We have 2 more polling questions. And there's a barcode. I'm going to talk a little bit about discussion before we go into the polling questions. We're really hoping that after all of these really rich presentations, sharing of some amazing resources, lively chat conversations, that you really take this time after these polling questions to use your raise your hand icon, unmute your mics, turn on your cameras, and really engage with our panelists. So hopefully you've been thinking of questions along the way, but they are open to feedback and to answer any concerns you may have. I do want to remind you, because it's come up a couple times in chat, that we will be sending all the resources plus many more that our presenters shared today after the webinar. And we will also give you a recording for anything that you may have missed. So if you would like to, for anyone who needs to scan this barcode who didn't do it initially, if you scan this QR code on your phone, you'll be able to answer the question. And the first polling question, this is really where we want to know about you. The question is, which age group is least protected from maltreatment, either at home or in the community, in your country, in your region? But which age group do you find has the least amount of protection with your current resources?
Wow.
We'll give this a little while for these answers to come in. Anyone who is not able to get this barcode to work, just type your answer in chat and Holly will answer for you from her phone.
This I find very interesting because it is something that we do see here in the US. A lot of our child abuse evaluations and preventions really focus, especially in the hospital, on the kids birth to 5. But we do know that abuse is unfortunately a childhood problem. And I think sometimes a lot of the resources are poured into the younger kids, which is not wrong, but we need to also focus on resources for our older children.
Mm-hmm. And unfortunately, in some of the calls that we get, it's a secular thing where a parent will call in looking for resources and help, or just to talk to someone about a situation that happened with their young child. And then through the course of the conversation, you find out that they too were a victim when they were a young child. So that perpetual cycle just goes. So
yeah,
it doesn't surprise me that see that high of a number.
Yeah. And it does, we are often products of our environment, what we've seen, what we've been exposed to. And then if we're not have these resources for these families, as they start having children themselves, they will often act in ways that were acted on them, thinking that that's the appropriate way. And again, I think with resources, with personalized conversations with these families, we can help change that.
Mm-hmm.
Any thoughts why the 10 to 13 category is one of the lowest? Are kids more compliant at that point? Maybe not as... I'm just kind of curious.
I was curious too.
One of the things I read about, and Dr. Rosenzweig could correct me, but sexual abuse seems to be correlated strongly with years of age, and some are seen after about that 10 years of age. I guess as these young women perhaps enter puberty, they are objectified more. So perhaps that's why we're seeing some of the least protection in some of the older kids, because these younger kids in the early adolescence maybe aren't objectified quite as much. I don't know.
But on the other hand, kids are more attractive to pedophiles before they develop secondary sex characteristics. It's, the older kids are attracted to the hebephiles and attractive to the other types of offenders, but the prepubescent kids, are at risk. Usually the kids in latency age are the strongest target for the pedophiles, the classic pedophile.
Great insight. Thank you.
And real quick, we have a question. Rajiv, do you want to answer your question or ask a question, please?
Yeah, so, first of all, I must say, I'm speaking from a very, very far away place, maybe about 16 or 20,000 miles away from New Delhi in India. And I'm really, really impressed, the amount of work that all of you have done. And today, in such a small, short time, you have touched upon so many resources, so many modules and models. So congratulations to all the speakers. You see, my question specifically relates to, preventing violence against women and girls. Being a pediatrician, I was trained to just prevent violence against children, that is both boys and girls. But lately, we run all those SDGs and everything that you said just fit into the picture that I practice. We run a mobile health van to provide access to health care in some of the most marginalized remote rural villages here and slums where migrants are plenty and no access to health care. So when I go there, I can tell you really quickly the stories that we see a woman coming with a bleeding head because the alcoholic husband actually beat her in the night, or a woman coming because she was kicked and pumped because she did not cook the meal on time. A scheduled caste woman was thrown away by people from the higher caste. We also see a lot of patriarchy where suddenly you realize this young child blossoming so well, when she gets puberty, she's forced into early marriage. So all these things that we see are something, what we really need to have a strategy that we need to prevent both violence against women and girls together. We need to have some strategy because, we can't just work in silos anymore. I mean, that's what my impression is after having worked in this field, practiced. I'm trained in the US at some of the top residencies program in the US in the University of California at San Francisco. And then I did a postdoctoral training in the Children's Hospital of Los Angeles. And for the last 20 plus years, I'm back at my home in India. And I relate to a lot of US professionals. I bring them over here and we have an active collaboration with the Johns Hopkins Bloomberg School of Public Health. So I do research, but I really struggle. I don't have a strategy really to prevent violence against women and girls. And I've lately been thinking maybe because 50% are boys and men, our strategy has to focus on men and boys. And I go back to, I'm currently the chair of the ISPAN board. And I go back to about 10 years ago when Joan Van Niekerk was the president of ISPAN. We did a ISPAN thinking space where we looked into the strategies for looking at men and boys as a strategy. But we had hardly any publications, like it's been about more than 15 years. So if you had any resources related to working with men and boys, it'll help me develop a strategy to work against prevention for women and girls and boys together. So
Thank you, Rajiv. That's such a great point.
That is a really great point. Yeah. Really great.
So any response and, really resources that focus on men and boys?
Off the top of my head, I can't think of specific resources, but I absolutely agree with you. I think, again, as we look back to those various forms of social determinants of health and risk factors for intimate partner violence, for sex abuse, a lot of it talks about, hypermasculinity, adherence to gender specific roles, again, what these children are growing up with in expectations of what a boy does, what a girl does. And then obviously we grow up to be men holding those same opinions, which in my opinion are wrong opinions. So I don't have that I'm aware of specific studies, and I know that is helpful as we try to implement programs, but trying to change the culture norms is something that takes a long time, but is something that can be started. If I find any resources, Dr. Singh, I will definitely reach out to you.
No.
Let me, I could recommend two. The National Sexual Violence Resource Center, NSVRC, I apologize, I typed it incorrectly into the chat box, has very good materials directed toward men and boys and acculturating men and boys. There's another nonprofit in the US called Ralliance, RALLIANCE, that was funded by the NFL, the National Football League, specifically to address the issue of toxic masculinity and to develop resources on the topic. So between NSVRC and Ralliance, you should find good materials. Both of them are organizations that develop things based on research. They're evidence-based materials.
Thank you,
Thank
Janet.
you.
That's very helpful.
Thank you.
We have
So
a couple-
Oh, sorry. I'm just going to have just a quick look at the polling results and I'll pull them off. But any surprises here to our panelists? It seems like physical abuse neglect, is very high. Obviously, child sex abuse, intimate partner violence, and sextortion. Very little gang involvement being, issues. I know that we're primarily focusing on potentially in-home and, association of, people in close proximity with the victims. But any insight on this from our panelists? Were you surprised?
Mm-mm. I'm not surprised, only because we know, at least in the United States, the statistics that are coming out that the physical abuse, domestic violence increased lots during the pandemic because of the isolation. So that doesn't surprise me.
Nor me. I mean, in general, when we look at all the categories of neglect, when we look at US data,
Yeah.
neglect is more common. It's much more difficult to identify. Where physical abuse, we're seeing the injuries either with our eyeballs or through imaging. And we have protocols to address workups for children who we think might be abused. So that does not surprise me.
And at this point, Sean, and to our other panelists, Barb and Janet, we just wanted to open it up. Holly will kind of take a look at chat and see if there's any questions. But for our audience, again, we'd love for you to turn your cameras on, engage. If you'd like to ask your question directly, feel free to use your raise your hand icon, or just if your camera's on, give us a wave, and we'll make sure that we give you access to our great presenters.
I do have a question. I have a couple of questions in the chat, and I'll go ahead and ask them. And whoever wants to answer it, jump in. My question is, what programs and services are available to address the problem from a toxic masculinity perspectives in a way that will change the future?
So my thoughts on toxic masculinity is, something again that is addressed on multiple levels. I believe things like the NFL and other high profile celebrity type things, athlete type things, who a lot of young men and young boys look up to, may be helpful if they send out messages, if they send out strong messages when their players or their executives commit violence against others, against women. They are slowly evolving. There was the incidents early in the 2000s and weren't handled well. So hopefully that'll help. I think education also on the more local level through providers may help. I think it's going to be a multi-level aspect, and it's going to be a long change when you just need to stay the road.
Thank you, Sean. Francis, I saw that you had your hand up. Would you like to ask your question?
Yeah, I mean, I appreciate you giving me the opportunity. I actually realized I'd be more interested in other people's questions than mine, so I'll come back to it if I. Yeah.
So do you want me to read yours, Francis? I have your question.
Yeah, I mean, I'm always full of questions. So, but okay. Yeah, if you want to read that too. I mean, okay.
Let me go ahead and read
Thank
it.
you so much for
Yeah.
this talk. I just really appreciate everything. So
So Francis' question, he put it in the chat before he jumped on, but can the panelists speak to the connection between physical abuse and sexual abuse? I personally feel that physical abuse is often more visible since it leave outward, since
since it leaves outward signs,
Okay.
that you can usually see, like injuries or people have to go to the hospital where, even if there's, I think it's probably clear.
So if I could just talk about the mirror image of that, in that sex abuse often doesn't leave physical signs at first, and it's much more easy to hide. It's much more easy for families to appear to be the good, upstanding members of the community while something very untoward is happening to the kids at night. I mean, again, there's a continuum of family dysfunction. So when you have a family where there's a huge amount of dysfunction, you're liable to see all the types of maltreatment, psychological, emotional, sexual, because nothing matters but everybody taking care of their own needs. Kind of the ids run rampant, and there's, in a family, but, the need to be sadistic is a very specific psychopathology. Sex abuse can happen for a million different reasons. Again, we're learning more about peer on peer, an older sibling to younger sibling, where the parents don't even know anything about it. So it's a difficult question to answer because there's so many different types of child sex abuse. But you are absolutely correct that physical abuse is going to leave signs that are easier for folks in the community or at school to pick up.
Thank you, Janet. And Gretchen, I know you have your hand up. Would you like to ask your question?
Sure. Oops. Just lost you. Okay. Hi. Sorry. I'm Gretchen Bachman. I work at the Department of State and I work on our overseas programs for children. And I just, there were a lot of questions about what's out there that's evidence-based, and just want to point out to all of our colleagues overseas that there's quite a bit that has been tested. Parenting support to prevent violence. There's also working with boys and men, different interventions. And if you want to read more about them, the World Health Organization website, if you put in INSPIRE, INSPIRE, it collects a number of different evidence-based interventions and examples. So just to say there's a lot out there. When we use a lot is Parenting for Lifelong Health. It's freely available, which not all US-based stuff is. So that's just it. There's a lot there, and just pointing people out. Thanks.
Thank you, Gretchen. That's very helpful. And Sahel, do you have a question you'd like to ask?
Yeah, hello.
Hello.
This is William Thomas. I'm having this meeting for Mr. Suhail Sadiq. Actually, he had a doctor's appointment and he has gone there. And firstly, I would like to add that today's meeting was so very helpful. It has so useful material that we believe that we can implement in our society. So my question is that here in Pakistan, we are working for minorities, especially Christians, right? And because we are in minority here, there are many cases of forced marriages, all right? Girls from ages 8 to 12 to 16, they are forcefully converted to Islam, and then they are forcefully married to Muslim people. And I believe that because we have been growing in a society where our education is not on the top-notch priority, so it becomes hard for small children to identify, and so they become the prey for this whole scenario. There are many cases like Arzu. It was actually held internationally, and I just would like to ask, what can we do? How can we offer them protection?
That I don't have any. Yeah, I was gonna say I don't have a specific way because I'm not knowledgeable in that area, and I do apologize. I wonder if either anybody else who's listening to this or if Gretchen knows of anything from the Department of health, the U.S. Department, or from who might have resources on that for this situation?
And I have to apologize. Could you repeat the type of intervention that she's looking for?
Forced marriages.
Yeah, no, there are, I would have to look, there really is quite a bit. If you look on USAID's website, but there's also Girls Not Brides, which is an international organization that does quite a bit in this area. Colleague from
Well, yeah, can I answer and help her out a little bit, if you don't mind? This is Rajiv. So I am practicing now in India, which is a handshaking distance from you. And let me tell you, one of the great things you can do is to look at the SIVAC. SIVAC is the South Asia Initiative to End Violence Against Children. And the boss there is Rinchen Chopal, who's also a SPEN member. And we're trying to get him into a country partner. So this is 7-country intergovernment agency. But you know what? You also need to look at your own laws. Obviously, this is an extreme amount of violence. And in this international community here, there cannot be just one set of solution. It has to be a local solution to this really problem. And you know why this happens pretty much in South Asia. I also know child marriages are so traumatic. I've seen so many girls, their families, their lives being totally through torture, through exploitation. In my country, there's a law. There's a law that there's called Protection of Children from Sexual Offenses. Under that law, and also there is there's sex with any child, boy or a girl below 18 is a crime. So that's one law. There's another law, preventing child marriages. Okay, that is, nobody would get married under the age of 18 for girls, under 21. But these laws mean nothing because, it's just poorly implemented. And it is really the civil society that needs to take up this call. And this is a human rights issue, really. And I think that's the way out I can see otherwise. And implementing the laws, most of the governments, whether India or Pakistan, do not set aside funds enough to get their laws implemented, to address the social determinants, and also reach out to the communities where they really need to go. Most of the people don't know what their rights are and how to fight these systems.
Great point, Rajiv. Thank you so much.
Just if I could share with our colleagues from Pakistan, I was part of a team on one of the State Department funded grants that was developing very community-based, neighborhood-based work on sexual violence prevention. And it was out of the Information Technology University of Punjab, ITU. And if anybody's interested, I'll dig in my files and find the contact, but they were developing a program, having it, evaluated by local university researchers, specifically being down at the community level. I mean, the legal level is critical, but we've got to start at the community level. So that's at least one good effort that I can share information about.
Thank you, Janet. That is very helpful. I want to let everyone know that we are actually at time. If there are any additional questions that somebody would like asked, please let us know.
So Jane, Jane, sorry, I just put in the chat as well. These expert panelists can really help me with one more response, I'm sure. Very quick one. Sean spoke about the socio-ecological model, which I believe is the best way forward if you have to work in these marginalized communities. But Sean, you also need to talk about a little bit about the faith-based actors and the religious leaders in these communities and what role they can play in prevention of violence. Because you know what, when the COVID struck, my nonprofit, in fact, just published a publication in Frontiers in Public Health as an impact factor close to 7. And we looked at the role of faith-based actors in improving the vaccine acceptance. And these guys were not taking, firstly, they were not taking any COVID vaccines. That's 5% in the whole community. And these guys were not then taking, the routine childhood vaccines because they were scared they were mixed up with COVID. And these are, and for my colleague from Pakistan, the population I'm serving, there's 90% more Muslims there. And they have a certain cultural background that is so common, whether it's India or Pakistan. So the role of faith-based actors is extremely crucial. And we as doctors have not engaged with them. And I think I want Sean to enlighten us.
I don't know if I can enlighten, but I absolutely agree with you. And I did have it in my notes and I didn't highlight it, but I know here, in the US and in my area in Phoenix, working with our faith-based communities is important because these families spend more time in these communities than they do in the doctor's office. Hopefully they spend more time there than they do in the emergency room where we have access to them. So I think working with the faith-based community to understand their questions and their concerns surrounding whether it's vaccines, other childhood health initiatives, on discipline, on sexuality is important. And same as when we talk to a family, once I understand what their concerns are, I can have a conversation with them instead of just a lecture. So I agree, we need to engage more because it is a huge part of a lot of people's lives around the world. And it is a great avenue into making some of these changes.
Yeah, but Sean, can you get us an evidence-based publication on this material? Because that'd be really helpful resource for us to take us develop something internally ourselves, particularly in violence. I really probably don't have such brilliant access to resources from India than you have from sitting in the US. So if you have my email, and Jane knows my emails as well, if you can just send us some material, all the three, the faculty who's presented, any resources on preventing violence in women and girls by the faith-based factors, we'll really appreciate that. Thank you.
I will actually reach out to my librarian today.
Okay. Okay,
Thank
great.
you, Sean. And
Great.
then we can send that in a follow-up email as well. I'm sure
Yeah,
others
please,
were curious.
please.
Okay. So
Thank you.
Sean, I would love to just see if you or Barbara or Janet have any closing thoughts before we wrap up.
No, I just want to say, again, most of our resources were very US based, and I do apologize for that. That is the area I work. But I do want to learn more from the international community to the areas that they struggle with in their community. And if in any way I can help, whether it's getting research, it's other things, I am more than happy to do it.
Let me tell you, Sean and Barb and all the Janet, we need to have these dialogues at a span where there'll be multi-country participation, people from low middle income countries engaged in, planning these, virtually, because it's really hard to travel and meet each other. There was a time that Howard Yubowitz, when he was on the board, he presented on neglect as it is perceived and treated in the US. Well, I gave the Indian as well the South Asian perspective. But for some reasons that has not taken off since we had these virtual things. But it is time that we need to engage multidisciplinary and also multi-country and learn from each other's experiences, because I have learned so much from today from all of you that I can't thank you enough. Thank you very much.
Thank you, Rajiv. That was a great closing comment. I would also like to ask our panelists if they would be interested in sharing their contact information. We know you're all very busy, you have your own careers, and but you can let me know that via email and we can add your contacts to the follow-up. And just a reminder, first of all, I don't think I've ever seen a chat box so lively in the 5 years I've been here. So I want to thank the audience for incredible participation in that. I think it speaks to the quality of the information that you presented as panelists, the engaging topics, the critical nature of the topics you presented. And just a reminder to everyone that links to all the resources presented will be sent to you in a follow-up email, as well as this Zoom recording from today's session. I know people, had to come and go based on the time. So the full recording will be available. And we will also ensure that you receive a certificate of attendance. And if for whatever reason you are not able to access any of the links in the email, this will also be located on the homepage of our website. And then I want to talk a little bit about some upcoming events and actually some current events at ISPCAN. The reason why we reached out to Sean and he, again, recruited Janet and Barb to help us is that we are in the middle of an ISPCAN prevention campaign. It's been running through November. It's November 1st to the 19th. And you'll see it on our website. And this webinar is part of that, as well as an additional webinar we'll have in a couple of weeks. But we're focusing on 19 days of preventions. We have tips, tools, resources. You're welcome to download any of these resources and to translate them into any of your native languages. If you want to send us back the translations, we can post those as well. And we'd like you to use our hashtag to continue to connect with us on a global level through social media. The hashtag is Rise Up to End Child Abuse. And all of this, these processes and these programs, these webinars accumulate to hit the anniversary of November 19th, which is the World Day to End Child Abuse. The second part of our prevention webinar series will happen on November 17th. This will speak to trauma-informed mental health care and prevention in children at risk. So really focusing on the mental health side of victims, increasing resilience in traumatized children. And we're just going to look at one country, the US's system of care around prevention, the mental health of parents, children at various stages, the tools that work, the challenges, and really inviting a global dialogue to that. Zlatina Kostova, Director of Training and Lifeline for Kids, will be one of our presenters. She's at UMass. And Dr. Brish Kishan, a child abuse pediatrician and psychologist focused on trauma-informed therapy in Utah. And that will be November 17th. And the marketing for that will go out today.
Excellent. Excellent.
Oh, good.
Excellent work. Janet, excellent work by Holly and you. And you know what? All of you who are on this call, ISPAN is doing a stellar job in preventing violence worldwide. We need all of you to promote this golden opportunity we have. Prevention is better than cure. If you don't prevent, I tell you, we will not be able to respond. And I've actually rotated with my friend and mentor, Martin Finkel. I've taken time off, a sabbatical with him. I tell you, it's not easy to manage child maltreatment, even in the US when you have all these resources. So let's all focus on prevention and we need to pool our resources. This is our strength. We are all multidisciplinary. We are also working in different regions. There can be great ideas that we need to share. And, again, physical side congresses have become so hard that, this only way we can do is through these meetings. So thank you very much for all of you to participate. Thank you, Jane.
Thank you, Rajiv. What a great endorsement. So very much appreciated. And Rajiv just set the tone for our membership pitch. If you're not a member already, for as low as $35 a year, an ISPCAN membership gets you deep discounts on our congresses and other events, free publications, masterclasses, webinars, and really a subscription to our peer-reviewed academic journal, Child Abuse and Neglect, the International Journal, which, by the way, was rated #1 on Google Scholar for social work. And really it gives you a platform to engage and take on leadership roles within the organization and to connect with fellow travelers on this really difficult journey that we are all on. And I think Barb said it, especially breaking the cycle, our focus on prevention. If we can break the cycle of abuse, then the impacts are felt everywhere, globally, through economics, through, mental health, through obviously the healthcare system, which is so challenged. So again, where our focus on prevention, I think, is unique.
Exactly. So Janet, very well said. And if I don't mind, I give another pitch to the membership. We all want you to become members and we all want you to stay our members. Keep paying the fees annually, regularly. It's very cheap. I've never seen a cheaper international membership ever. And if you don't do that, we as an organization will face hardships, to be honest. In this particular world, it's very difficult to organize these physical congresses. Still, there was, with the Ukraine war going on, imagine I had to travel to Estonia and my wife refused. Normally she would have agreed, a European journey, why not? But, with so much of scare and which is so difficult for us to even do that meeting. because a hybrid Congress was so difficult. So please remain our members, and because membership will strengthen all of us, will strengthen ISPAN and through us, and we will reach out to you more often. Thank you very much.
Thanks, Rajiv. And Sean, Janet, and Barb, I can't thank you enough. I wasn't making up the statement. I have never seen a chat so engaged, and I hope that you were able to, also spend some time. We will see if we can get the chat log to our presenters as well. I think there were some questions in there that may have happened early and didn't get answered. So thank you so much to everyone. Again, heartfelt thank you to our presenters, and everyone have a great day or night wherever you are joining us from.
Bye-bye.
Thank you guys very much.
Bye, everyone.
Thank you.
Thank you. Goodbye.